Hi, my name is Austin Larson. I'm a physician at the University of Colorado School of Medicine. I practice at Children's Hospital Colorado. I'm a pediatrician by training, a medical geneticist and a biochemical geneticist. I help to direct the Mitochondrial Care Network clinic here in Colorado, as well as seeing patients with the genetics and metabolic service here at our hospital. I do see adult and pediatric patients, specifically in mitochondrial disease, but my primary area of expertise is in pediatric genetic and metabolic diseases. So I'm going to talk to you today about the COVID-19 pandemic and what the implications are for patients with mitochondrial disease. So I want to acknowledge that this is really an unprecedented time that we're in. We are experiencing a once-a-century pandemic that is currently going around the world, impacting people in so many ways in terms of their health, their finances, their social circumstances, their family circumstances. Really a disruptive time for a lot of people in a very difficult time. So I think it's important in a venue like this mitochondrial meeting that's now virtual and taking the place of what had been a regular annual meeting to discuss mitochondrial disease. I think it's important to take this opportunity to talk about what we do know about COVID-19. Think about how it might interact with mitochondrial disease, and to discuss what the recommendations would be for patients that have mitochondrial disease. I'm really going to focus a lot on this first question. We have a really nice lineup today of talks that are oriented at patients and families, and a number of the other speakers We'll touch on specific recommendations for patients with mitochondrial disease. And so I do want to focus really on the question of what we know about COVID-19, and hopefully you can use that as an introduction in terms of the questions, both for me during the Q&A session that I'll do, and also with other folks that will be speaking today. I want to let everyone know that I'm recording this on June 17th. This is a pretty quickly moving situation, and we may know things in a couple weeks when you're viewing this that we don't know now. And there may be an opportunity to talk about a few updates during the live Q&A session that we have then. So COVID-19 is the word that most of us use to describe this pandemic. And what COVID-19 stands for is the coronavirus related disease that started in 2019. So this did start in late 2019 in China. Obviously, the manifestations for most of the world have happened in 2020. COVID-19 refers to the clinical syndrome or the disease that results from people who are infected with a virus called SARS-CoV-2. So SARS-CoV-2, the name comes from the severe acute respiratory syndrome. That name was coined 17 years ago during a prior outbreak. And that prior virus is now called SARS-CoV-1. The virus that's currently circulating and causing this pandemic is closely related to that virus. So it's been called SARS-CoV-2 because they're so closely related. Those two viruses are the most closely related, but there are other viruses in this family of coronaviruses. So coronaviruses are so named because when you look at them under a microscope, they look like a crown. So corona means crown. And these spike proteins that stick out from the virus, they give that appearance of the crown, and hence the name coronavirus. So there is this current coronavirus, SARS-CoV-2, that is in a pandemic stage, meaning that it's circulating throughout the world. There are also what's called endemic coronaviruses. So there are 4 separate coronaviruses that are considered endemic, meaning they don't ever really go away. since we've known about coronaviruses, they've been circulating in the population. They circulate at relatively lower levels. They cause relatively milder illness in comparison to SARS-CoV-2 and SARS-CoV-1. And they often cause symptoms of a common cold or a respiratory infection, and most frequently in children in comparison to adults. So if you think about the difference between SARS-CoV-1 and SARS-CoV-2, the reason that one of them was successfully contained and the other became this global pandemic is actually a little bit paradoxical, in that SARS-CoV-2 causes a somewhat less severe clinical illness than SARS-CoV-1. Because SARS-CoV-1 was so severe, people became symptomatic sooner after they became exposed to the virus. They were able to quarantine themselves. They were also so sick that many of them weren't out going to work or walking through cities, riding public transit, things like that. Whereas with SARS-CoV-2, there's a significant fraction of people that have quite a mild illness. And as a result of that, they are traveling internationally, going to work, things like that. And that's probably the reason that SARS-CoV-2 or COVID-19 has become this worldwide once-a-century type pandemic, whereas the original SARS was able to be contained. It still significantly affected cities like Toronto and Hong Kong, but it didn't become this global pandemic that we're currently experiencing. So the way that SARS-CoV-2 affects the body is that it's initially a respiratory infection. So the virus enters the body through the nose or mouth or eyes. It infects the cells of the upper respiratory tract. It spreads to the lower respiratory tract, and it causes cell damage. So that initial experience of being short of breath and coughing, that's related to that viral infection of the viral propagation and cell damage that's happening. However, with SARS-CoV-2, we now know that there are a number of secondary effects, and in a lot of cases, those secondary effects may actually be more clinically relevant than the primary infection. So the SARS-CoV-2 virus spreads to blood vessels. It can affect the heart and the kidneys and the digestive tract. And potentially most importantly, it causes in some people a really robust immune response. The chemicals that mediate that immune response are called cytokines, and those cytokines can sometimes rise to such high levels that that's something called a cytokine storm. And so a cytokine storm has been documented in a lot of the people who have really severe illnesses, who are in ICUs, or who have a fatal case of COVID-19 as the driving process. So for a lot of folks, it's that secondary immune response rather than that primary viral infection that may be most clinically relevant for what they're experiencing. The patients that are hospitalized with COVID-19, the vast majority of them have fever and cough and shortness of breath. Smaller numbers of people have muscle aches, diarrhea, nausea and vomiting, some neurologic symptoms like confusion. We know, and I'll go into this in more detail, that people with underlying health conditions such as chronic heart disease, diabetes, chronic lung disease, chronic kidney disease are at higher risk of being hospitalized and are at higher risk of having severe outcomes related to SARS-CoV-2 infection. This is a screenshot from the Johns Hopkins University Coronavirus Resource Center. The screenshot was taken on June 16th. And at that time, there were over 8 million documented cases around the world and over 440,000 deaths around the world that have been attributed to COVID-19. That pandemic is continuing to propagate. There may even be an acceleration recently in the number of people who have been documented to have the illness around the world. The shape of the pandemic has been different in different populations. So this is a graph from a website called Our World in Data. This is the number of total daily deaths, starting the count at the day when there were 5 new deaths reported related to COVID-19. So you can see that the United States had a really rapid rise, a really high peak, and we're well below that peak now. We're approaching 100 days from our first day when we had 5 people that died of COVID-19. Some other countries like Brazil and India are now becoming the epicenter of the pandemic. Russia would also fall into that category. They've seen a slower rise, but now are at significant numbers of folks who are infected and folks who are dying due to COVID-19. Some of the other lines on this graph are the United Kingdom, Italy, and Germany, all of which had significant peaks relatively early on and are well below those peaks now after a couple months of really intensive interventions in those countries. So when we define cases, it's really important to understand what types of testing can be done for SARS-CoV-2. There's really 2 main ways that we can document a case. So the one that most people are probably familiar with is the nasal swab. So that's a test where you put a Q-tip or a swab inside the nose, try to brush up against the cells of the upper respiratory tract, and then you do a test called PCR, or polymerase chain reaction, where you're looking directly for genetic material from the virus. And that will be a positive test if you are acutely infected, if you currently have the virus. There's some debate about, some people have lingering positive tests for 3 or 4 or more weeks. There's some debate about whether there's significance of that or whether those people just kind of have some lingering genetic material from the virus. But it's important to know that that test will be negative if you miss the window when a person is acutely infected. And so PCR testing may result in significant undercounting. There also may be technique issues. So if someone didn't swab well enough or didn't run the test correctly, you can have a false negative test. There's another test which has been developed a little bit later, which is a blood test to look for antibodies to see if you previously had the virus. So this test would be negative if you're acutely infected, but then would become positive later on, and that would be a documentation of the fact that the immune system has been activated and has responded to the virus. So we get different information from these 2 tests. There's no perfect test. They both have benefits and drawbacks. And I want to talk a little bit about the implications of just relying on that PCR test. So there are 2 kind of case studies that I want to point to that I think help to make our understanding of this data a little bit more nuanced. So there was an aircraft carrier that got a lot of publicity, the USS Theodore Roosevelt, where a lot of the sailors on the carrier were impacted by COVID-19. They were being tested quite frequently, but cumulatively only about 25% of the sailors tested positive. There were about 5,000 sailors on the carrier. There was a follow-up study of the sailors that had been on the carrier, and they found that 60% of them had antibodies showing that they had been infected at one point. So what that tells us is that the PCR testing, even with pretty intensive testing of a confined group of folks, it can result in a significant undercount. And that undercount is important because that's what gives us the denominator to understand what is the case fatality rate and understand how it's impacting different populations differently. There was again, a well-publicized outbreak of SARS-CoV-2 infections in northern Italy. The city that was most heavily impacted by that is called Bergamo. So Bergamo is just outside Milan. And there were over 6,000 deaths in Bergamo. And that was resulted in a very high case fatality rate based on the number of documented positive PCR tests. But in a more recent follow-up, looking at antibodies from that population, it looks like 60% of the population of that city of 1 million people had been infected at some point. And given that that rate of infection was much, much higher, that means that the fatality rate was actually a tenth of what it appeared to be, given the breadth of folks that truly had the disease, but either had a false negative test or a PCR test at the wrong time, or just never got tested. So taking that data, we can generate an infection fatality rate, meaning the number of people who die as a fraction of those people who had infection. And in a place like Bergamo, Italy, where there are a relatively older population with more comorbid illnesses, the fatality rate appears to have been around 1%, if we rely on that antibody number indicating that a larger segment of the population had the infection than we initially thought. On the USS Roosevelt, there was one death out of almost 3,000 infected sailors, meaning that's a 0.03% infection fatality rate, indicating that that population is relatively less likely to have severe illness. So the population on a carrier would be much younger, much healthier individuals. So that probably gives you a sense of just how widely variable the severity of this illness can be in different populations. So as I mentioned, one of the things that is most indicative of the likelihood of a severe illness or the lack of likelihood of severe illness is age. So those that are older are much more susceptible to severe illness. We know that male sex and the prevalence of underlying illnesses are also significant risk factors. So I can talk a little bit about my experience working at a children's hospital. They have been collecting data here, testing every admitted patient. And what we found is that our data have been pretty consistent with those data that have been generated around the world, showing that children are much less likely to be infected, and when they are infected, much less likely to have severe illness as a result. So some recent papers that have come out have started to think about the trade-offs that we're making in terms of the societal interventions that we put into place. And the question of whether or not to close schools is a really important one. So when we think about the trade-offs that we're making, we're really impacting children in terms of their education. We're impacting families by kids not being in school. And so it will be important over the next couple months as we make the decisions about whether to reopen schools in the fall and how to reopen them, to use data like the data that we're generating here at Children's Hospital, like the data that have been generated in other countries about the rate of infections among children, the transmissibility of infections between children, and the rate of severe illness with children. So I'm not here to tell you right answers, but we're making trade-offs, and we're making decisions as individuals. We're making decisions as healthcare providers, as societies, in terms of how we want to respond to this. And I do think that it's important that we have a really nuanced appreciation of the data when we make those decisions to try to make the trade-offs as optimal as we can. So these are some data from Colorado. Again, this is a screen capture from June 16th. So this is a rapidly evolving data set. But I do want to draw your attention to the number of positive tests among children less than 9 and between 10 and 19. This is fewer than 5% of the overall positive tests, whereas folks in that age range are 25% of the population here in Colorado. So clearly significantly underrepresented. The other thing that you can see, this blue bar is folks that are hospitalized. The gray bar is folks that tested positive but weren't hospitalized. And the dark blue bar on top is the number of deaths. And you can see that both the rate of hospitalization and fatality increases with age. Just to give you a sense of the progression of this epidemic with time, one way to look at it is the test positivity rates. So of all tests that are done, what fraction of them are positive? So at the peak of the epidemic here in Colorado, that was mid-April, a quarter of all tests that were done were positive. This is PCR tests. Whereas now it's more like 2% are positive. So we're in a lull here. I think everyone expects that rate to increase somewhat as the restrictions are lifted, as more people are venturing out, getting out of the home, going back to work. And I think, again, in terms of the trade-offs that we're making, it's that question of what are the things that we can do that are relatively low impact, that are just kind of smart ways to modify our lives a little bit to decrease that likelihood of transmission, decrease the likelihood of getting the virus and getting the illness associated with it. Looking at that case fatality rate by age, we see the same pattern in every country that's been looked at. So this is another chart from this website, Our World in Data. You can see that the case fatality rate is extremely low in children, quite low in young adults, but then as you get to folks in their 50s, 60s, 70s, and 80s, there's an increasing rate of mortality related to the virus. And I want to emphasize that these case fatality rates, again, are likely an overestimate because we're undercounting that denominator of the total number of cases based on just the PCR test. So the absolute numbers are probably an overestimate, but the relative numbers of different age groups, I think, is not in question at this point. So this is clearly a much more severe virus in the way that it impacts folks that are older than folks that are younger. Looking at another set of data, the fatality rates and the rate of severe illness are much higher among those who have comorbid conditions than those who don't. So again, I think these numbers are likely to be overestimates, but the relative numbers in comparison to one another is what's important here. So folks that have cardiovascular disease, diabetes, chronic lung disease are clearly at much higher risk than folks that don't have those conditions. And as it relates to mitochondrial disease, cardiovascular disease like cardiomyopathy, cardiac arrhythmias are much more prevalent in the population with mitochondrial disease than those that don't have mitochondrial disease. Likewise, diabetes is clearly associated with mitochondrial disease, as is chronic respiratory disease in the form of respiratory insufficiency or respiratory muscle weakness related to myopathy. That's clearly something that we see in folks with mitochondrial disease. So the relative risk of COVID-19, again, not the absolute numbers here, but the relative risk in comparison to the population, I think is really important in terms of helping us to make good decisions. As it relates to pediatric cases, I talked earlier about there being really two components here of SARS-CoV-2. There's the infection, but then there's the immune response to the presence of the virus. And it appears that in children, that immune response is relatively more significant in terms of the children that do, those few children that do have severe disease related to this virus, many of them, it's only the immune response and not that primary viral infection that's resulting in the severe illness. So there's this phenomenon called MIS-C, which is Multisystem Inflammatory Syndrome in children, which is an inflammatory syndrome that we see usually after the acute infection is completely gone, weeks later. We see that kids are getting very inflamed in a way that's affecting their hearts and their blood vessels. It can look like some other inflammatory conditions called toxic shock syndrome or Kawasaki syndrome. And it's clear that for children, this is the immune response to that viral illness and not the viral illness itself. And that impacts the way that that we go about treatment. So for the cases that I'm aware of, those kids have been treated with the medications that reduce the inflammation and try to tamp down that cytokine storm or the other inflammatory processes that are causing the symptoms. So this is something that we see in a small fraction of the children that have been infected. So what is a patient with mitochondrial disease or someone without mitochondrial disease? What are we to do? So we know that we have some effective ways to prevent infection. So wearing a mask clearly reduces the likelihood that two people will transmit the virus between them. That's probably primarily the person that potentially is infectious, but maybe has no symptoms, preventing them from spreading the virus. So that's really the primary impact of the mask. It's less benefit for the uninfected person and more the person who may have the virus but is asymptomatic, preventing them from spreading it. We know that social distancing works, that staying home works, but we also know that it takes a huge toll. So it has really significant economic implications and implications in terms of our general well-being. So not being able to see family members, not being able to see friends and colleagues is really impactful. And so to the degree that we can figure out ways to have those social interactions and to continue to do our jobs, but in ways that are safer with regards to viral transmission, I think that's really important. Folks that have symptoms need to not expose themselves to other people. So we have some social norms in different environments of not taking sick days or not letting a cold get you down. And at least for the short term, that social norm needs to change. And we need to make sure that people who are potentially infectious are not exposing themselves to other people in public or in the workplace. Hand sanitizer and hand washing, good hand hygiene clearly works as a way to prevent transmission. So these are all things that I know everyone has heard time and time again, but these are the interventions that we have right now in terms of being able to slow the spread of this virus. So what can we do? We will have a talk later today about telemedicine. So helping people to continue to get their health care in the home rather than coming to a hospital where there may be other infectious people. That's something that we've worked really hard on at my institution and at institutions around the country and around the world. There's a group here with the Mitochondrial Care Network led by Dr. Parikh and Dr. Kara, who have really made telehealth with regards to mitochondrial disease a point of emphasis, and they'll talk about that later today. So I encourage you to stay on the call here and listen into their talk. As I mentioned, we know about these things that are effective, but we also know that there are significant costs associated with them in terms of our social well-being and our financial well-being. And so as we learn more and more about the transmission of this virus and who's most likely to be impacted, we can start to make more nuanced decisions about the activities that we engage in. So mitigating risk, obviously the risk is lowest with virtual interactions like the one that we're having now. But mitigating risk might be something like socializing outdoors with a very small number of people. Hopefully those people are not ill. They themselves are taking those precautions that we talked about on the last slide and being careful about their own exposures. I think with some careful thought, we can have those social interactions, but in a pretty low risk way. In terms of deciding what societal interventions we put into place, or just personally what kinds of exposures we want to engage in, we can learn from what are called super spreading events. So super spreading events are places and times where many people have become infected by the virus. So many of those super spreading events have happened in meatpacking factories. So that has something to tell us about what are the circumstances in which the virus is most easily transmissible. Meatpacking factories are cold, they're enclosed, they're indoors, the people are working closely together. They're sometimes working with power tools that have the ability to spread air really broadly. I'm not an expert in occupational exposures, but that's being studied right now, and learning from that extreme case where the virus seems to be really easily spread, and sort of backtracking from there to figure out what are each of the variables that we can tweak, what are the incremental changes that we can make in our environment and in our circumstances that can make the virus less transmissible. This on the right here is a picture of a choir practice. So one of the most well-publicized super spreading events was a choir practice in Seattle, Washington, where one individual infected over 90% of the other members of the choir just in one choir practice. And that's probably a function of being indoors, of projecting. So the louder you're projecting your voice, the more distantly you're spreading those viral particles. Everyone around them is breathing deeply as part of their own singing. So that, again, is a very, very high risk scenario. And we can learn from that in terms of the interventions that we make going forward to be as safe as possible. In addition to our understanding of how the virus spreads and what we can do to decrease the risk of transmission, we're also getting better at studying and developing experience in how to treat people who are acutely infected and who are hospitalized. So I just checked clinicaltrials.gov this morning. There are over 2,000 studies listed that relate to COVID-19. This is a scenario, it's unfortunately in some ways it's kind of the opposite of mitochondrial disease in that it's something that really lends itself to clinical trials. So the outcomes that we care about with regards to COVID-19, they happen really soon. They're really objective. Is someone on a ventilator or are they not? Are they hospitalized or are they not? And those outcomes, yes or no, to those questions, that happens within a matter of days. We also have a really large number of people, right? Over 8 million people around the world, and many multiples of that that just have undocumented infections to draw from. So it's really an opportunity to advance the science very, very quickly, given that all of the preconditions are in place for pretty easily conducted clinical trials. Not to minimize the work and the expense that goes into that at all, but again, we have an opportunity here over the next couple months to make really rapid improvements in how we manage this condition. So this is a kind of some late breaking news out of the UK that came out yesterday. There is a pretty carefully conducted randomized trial of people who had standard care for COVID-19 and those that had steroid, dexamethasone, on top of their standard care. And they found that there was a significant risk in the decrease in the risk of death and in those folks that took the dexamethasone. So those little tweaks, those incremental tweaks like that are going to add up, and we're going to get better and better at managing this condition. We're going to get better and better at preventing the spread. So that's the goal. That's what the entire medical and scientific infrastructure around the world is mobilized for right now. And we're starting to make progress, and we're just starting to see the benefits of that. So specifically for folks with mitochondrial disease, COVID-19 has the potential to be a really significant illness. So folks with mitochondrial disease have a lot of those comorbidities that have been overrepresented in folks with admissions related to COVID-19. Things like cardiomyopathy, cardiac arrhythmias, diabetes, hypoventilation. All of those things are likely to be risk factors with regards to a higher potential for severe illness. That said, we can be aware of those complications, and we can actively implement management strategies to account for them. So one thing that we can do for folks with mitochondrial disease is to avoid prolonged catabolism. So there are different strategies of nutritional management for adults and children in ICU and hospital settings. In general, for folks with mitochondrial disease, we want to be more aggressive about providing calories. If someone's unable to get fed enterally, then that should be a parenteral or intravenous administration of calories like dextrose containing fluids and fats. We want to make sure that we're actively evaluating for potential complications and taking those into account. Things like neuropathy, myopathy, changes in the hormones. We want to make sure that we're thinking one step ahead about the potential complications that a patient with mitochondrial disease might have. I want to talk a little bit about the way that I approach this. If I'm speaking with an intensive care physician or a hospitalist physician who's taking care of one of my patients with a metabolic or mitochondrial disease, there's a middle ground to be struck. So the mitochondrial disease can't crowd out every other consideration in terms of the management strategies. So a good example of that is that when I am speaking with an intensive care physician, I might recommend that they start dextrose-containing IV fluids. And the response might be, oh, we really need to restrict the amount of fluid this patient is getting because they have pulmonary edema or they have edema elsewhere in their body. So then I might say, okay, so let's maybe change some of those calories to fat, and let's increase the concentration of the dextrose so that we can administer it in a smaller volume. And I think it's really important that there's a back and forth, that we as mitochondrial physicians understand the goals of the intensive care physician, what they're trying to accomplish. They have a lot of intuitive expertise as it relates to patients in particular circumstances in the ICU. And it's important that it's a two-way street in terms of the recommendations that are made, that we as mitochondrial physicians can provide them with new considerations about maybe new diagnostic studies or new evaluations to get, some changes in management, but we need to make sure that that still takes into account the expertise of that physician who's primarily caring for the patient in the ICU or on the hospital floor. So I would say that the main thing that can be done is just to make sure that those lines of communication are open and that that conversation is ongoing and that it's adaptive to the circumstances of the patient. As the circumstances change, that conversation needs to change in terms of what the goals are of care. There's a really nice paper, Dr. Parikh, who you'll hear from later today, is the first author on this paper that provides a consensus statement about standards for care for mitochondrial disease. So I I want to stop here and thank you for listening to this presentation. Thank you for being engaged and involved in the mitochondrial community. And I'm looking forward to the other talks that we have in the next couple hours. I think that those will be really informative, and I'm happy to take any questions that you have for the next 15 minutes or so.